On the Go podcast.
Breaking Cartilage Boundaries in 2040, live at ESCA 2024 in Milan with AGA President Professor Philipp Niemeyer from the OCM in Munich and Dr. Jari Dahmen, Amsterdam University Medical Centers, University of Amsterdam. My name is Taka Oshima and this is On the Go, the podcast all around orthoregeneration.
Yeah, so welcome to our podcast,
great
Professor
to be
Niemeyer.
here. Yeah.
We just shared some questions beforehand, and we always start with our first question to our guest, and it's how do you drink your coffee? Because this is the On the Go coffee podcast.
Yeah, actually, On the Go is what I'm doing. So I regularly have my private time in my car every morning when I have my coffee. It's Lungo Barista with some milk, but not too much milk. And it takes me probably 15 to 20 minutes to go to the hospital. And that's when I really enjoy listening to podcasts on the one hand side and also to have my coffee, my first coffee of the day.
Your first coffee of the day. And are you a type of person who makes the coffee with a full automatic system or semi-automatic? What's your hobby?
So I'm not professional barista. Yeah. So it's more completely automatic and just one finger in order to get my coffee. So it's nothing special about that.
Okay, but still a hobby that's in the making to become professional barista someday.
I don't think I will ever make this. So.
Okay. And you just mentioned that that you listen to non-medical podcasts on your way to the hospital.
Yeah, that's
your
typically
coffee.
about politics or any news topics. Interviews with interesting people.
Yeah, it's your way of relaxing in the morning to go to the hospital for a busy day.
Yeah.
And then in between cases or in between outpatient clinic or research day, do you have some safe spot in the hospital where you can just quickly go to relax and have a coffee, or is it just quickly in between?
So to be honest, as a surgeon, everybody is trying to hurry up between surgeries. So I try to limit the time. I also try to limit my coffees in between because that's quite a lot otherwise. And but for sure, there's definitely some minutes I just get back and have a coffee in between as well.
Yeah, and so so on the On Foundation dinner that we had in Sitges, we sat next to each other and talking about the podcast.
That was a really nice evening.
Yeah, and it's almost 1 year later, a little bit of like 10 months.
So thanks for picking up the idea to have this podcast here together.
And now finally we're here. And then you mentioned that you also make podcasts for patients. Could you tell us a little bit more about what that is and for who it is?
Yeah, this is actually a German-speaking podcast. So it's a national project. It's called Listen to Science. Why is it called Listen to Science? Because it's an audio podcast on the one hand side, but it's also because we want to give recommendations to the patients, which is actually based upon science or scientific evidence. And that's why we came up with this topic. But interestingly, so we started 1 year ago, and I'm doing this podcast together with my colleague and friend, Professor Mirko Herbert, who's also a knee surgeon at the OCM in Munich. And initially, we actually just came up with the idea to record our consultations, which we are really doing redundantly on a daily basis, and try to hand over this to our patients. And
you can hear the voice in your back of your head repeating
exactly, and that is something which really is something which is it really makes you an effort to just repeat the identical recommendations several times a day. And on the other hand, doing such a podcast project, you can give much more information to the patients than during just a 10-minute or 15-minute consultation. Yeah. And that's what we came up with. And at some point, we noticed that this podcast became quite popular.
Yeah. And so
so we are not doing any marketing on that, but obviously we have quite a bunch of listeners.
So it's in German, the podcast?
Yeah, so preparation time is 0.
Yeah.
So we just start spontaneously. We just choose the topic and try to be as authentic as we are during our outpatient consultancies and just keep on talking.
So in our show notes for the listeners who are listening to this podcast, we will share the link to
Yeah,
your
that
own
would be
podcast.
super cool. Yeah.
Is it something that you want to also spread to other countries, maybe for
Yeah,
English speaking?
I told you about the initial motivation, which
Yeah.
was about our patients. So
Yeah.
we didn't really came up with the idea to do that international wise. But on the other hand, as you might know, I'm also involved in an online education platform, which is more video based. It's not an audio based. It's called Winglet. And wingletcommunity.com is the URL for that. And we are thinking about having also a podcast project on that platform, which is more aiming on surgeons and physicians instead of patients. And this should be international-wise.
And do you hear sometimes from your patients back on the outpatient clinic, hey, it was very nice to have this podcast. I have all the information.
Yeah, interesting. Yeah, yes. So we didn't really aimed on getting more patients based on that podcast project. But interestingly, actually every day at least one patient comes because he was listening to the podcast and somehow got in touch with us. Yeah.
So they recognize that they have the injury that you were talking about, and then they were like, okay, these people know a lot about the injury and have a lot of information.
Exactly, and obviously there's a need for information, for medical information within the patient community.
Yeah.
And obviously the way we do that, at least, is in favor of some patients. So probably there's many people who don't like it, but obviously some do like it. So
Well, very nice. I think that's a great initiative, and although it's in German.
So we have talked. We have 43 episodes by the time we are recording today, and actually every episode is between 45 and 60 minutes. So we have probably 35 hours of talking about knee pathologies and knee surgeries, which I was never aware that this is possible. And we have still probably 50 topics on our bucket list. So
really? Wow. So enough to come.
Absolutely. So we are still
and then
continuing.
Maybe you can also shift it with your colleagues to other joints as well.
Yeah.
So,
but there's still some, until now it's exclusively dealing with knee pathologies and knee surgeries, but from time to time we have also guests inviting because we cannot really cover all topics perfectly.
Of course,
And shifting that to other joints might be a good project for the future. Thanks for that.
Well, great to hear that. And as mentioned before, we'll share it so that our at least I think German society part can also listen to it.
Yeah, thanks.
Well, that was what was one part of the podcast that I was interested to hear from you about. But obviously, that's not the only thing that you do in your professional life, because you're also a knee surgeon and doing a lot in the research and clinics in the cartilage lesions in the knee. Can you tell us a little bit about ACI and MACI that you're currently doing? What is it, and how has that field evolved over the last 20 years so that we can take a look to the future?
It's kind of scaring that I have to look back now, or that I can already look back over the last 20 years. But that's true. So actually, I first got in touch with cartilage repair when I was a student, and that was by chance because I was a student in the orthopedic department at the Freiburg University. And at that time, Professor Ergelet at this time performed his first arthroscopic ACI case. And I was actually running into that surgery without knowing what he's doing. I probably didn't even know at the end of the surgery, but this is just a little side remark on that. Afterwards, I finished my study in Freiburg, started working at the Heidelberg University. Interestingly, not getting in touch with cartilage repair at all. And I was there for 2 years before I returned back to Freiburg in 2004. And at that point, I again joined Matthias Steinwachs, president of the On Foundation, and Christoph Ergelet at that point. And then when I stepwise got involved in cartilage repair from the clinical side of view, but also from the scientific point of view. And I do remember that at that point, the Freiburg University was one of the first institutions performing ACI outside Sweden. I do believe it was the first, but I cannot say for sure, in Germany. And initially, we were preparing the periosteum patch, which was first generation ACI. And ever since, as you also know, it has evolved continuously. And now we are using injectable products, which I'm really in favor of. We can limit the surgical approaches, but this is something probably also all our viewers actually know about.
Yeah. So,
so I really got the entire development of ACL until now. So it's definitely something which continues. I more or less experienced that during my 20 years at the Freiburg University.
And so currently, what generation ACI or MACI are you performing?
There's actually 3 products available in Germany right now. 2 are provided by the company TTEC, which is the NovoCart 3D, which is a 3-dimensional matrix augmented ACI product. And the other is the NovoCart Inject product, which is an injectable hydrogel. This is a product I personally feel really excited about because it's not only a cell carrier, but it's also, I usually call it a smart biomaterial because it's anti-inflammatory. It inhibits vessel growth in the joint. It's anti-angiogenetic. And I was also leading the approval study for the European market approval. And also the study results are something which really convinced me. But I'm also using the third product, which is from the company Codon in Germany, which is actually the first product that achieved European market approval as a pharmaceutical, as you know. And this change from medicinal products to pharmaceuticals is definitely something which significantly changed the use of ACI in the recent years in Germany specifically, but all over Europe.
And is the hydrogel injectable implant, or is it something that you inject during an arthroscopic procedure?
No, when talking about ACI, we are always talking about local treatment of a focal cartilage defect. So it includes, as you know, debridement of the defect, opening of the joint. You can also do it arthroscopically in selected defect locations. But generally speaking, it's a surgery, so it's not comparable to treatment of early osteoarthritis using PRP products or hyaluronic acid. Still ACI.
And how do you make the differentiation between choosing for an hydrogel-based implant through, for example, the arthroscopy or the matrix assisted one?
Yeah, that's a good question. I do not have 100% rule for that. So I'm using the matrix in patella defects really frequently. But this is just a field decision. It's not really scientifically proven. But for the remaining locations, especially for defects which are really hard to reach during the surgery, the injectable hydrogel is definitely beneficial because it's much easier to applicate. The incision size is much less, and that's why I'm generally slightly in favor of that product.
And so obviously we're also talking about the future of local cartilage defects in 2040 in this podcast. Where do you think in the next 20 years will be? So, for example, imagine yourself in 20 years.
Difficult question. So what I'm a little bit disappointed of is that we did not really experience significant progress in developing new products within the last 10 years. So even the hydrogel product is available in Germany for more than 10 years now. And this is due to these regulatory issues. So taking a product from bench to bedside in the 1990s was a matter of months. And now it's a matter of years, talking more about 10 years than 2 years. And this actually leads to the fact that I'm slightly disappointed. And I don't believe that the major progress within the next couple of years will be new innovations in terms of products. Maybe there definitely is some interesting approaches, also technically speaking, in the lab. But I'm not sure if we can use that on a routinely basis in 2000. And what were you saying? 2040. What I do think that there is significant room for improvement is selecting patients. This is definitely the topic I'm also still working on. We are also interesting. I might be allowed to remark that, and we are doing an ICRS focus meeting on patient profiling in December in Munich. So everybody who's interested in us is invited to join that. And I do think that there is room for improvement in this field. Not only talking about what defect size qualifies for what type of treatment, which was basically the decision within the last 10 or 15 years, but I do think that joint condition, patient condition also may also influence what the best treatment is for a specific patient. And we don't know, to be honest, we don't know much about that yet.
And so if regarding this, if you would receive a personal grant of 20 million euros and you need to go towards 2040 and resolve the problem of patient profiling, what type of study or what ideas would you do?
I'm a super fan of some publications of a British group from Ovestry, and what they are doing is they are doing a biochemical characterization of the patient prior to cartilage repair. And what they are able to show is that on a proteomic analysis, they are able to correlate the results of their analysis to patient outcome. And this is something which is something I do consider promising for the future. Because you can easily use it. You can do these analyses by aspiration of synovial fluid, which is something which is absolutely feasible prior to a potential surgery. And once these works continue, and once we identify maybe marker proteins, which can be linked or can be linked to outcome parameters. This is definitely something I would invest some money in.
Yeah, and so that maybe also be not only synovial fluid, but for example, also some blood derivation in 20 years.
Yeah, that would be maybe even a less invasive approach to that. But what I'm saying is I really do believe that there are many parameters which we do not consider at all in our today's decision making, which might be super relevant for the future. So basically, when a patient comes to see me, I'm looking at the MRI. I'm look about defect size, defect grade. What I also think is really interesting, looking a little bit more around the joint. So we are just about to publish some data on whole joint MRIs and correlation to outcome. But this is also disappointing. So we do not find really hard and significant correlations for that. So imaging seems to be limited. We know about concomitant pathologies, which is super important, but we have learned that already 10 to 20 years ago. And this is part of daily practice. And talking about future achievements, I do think that these biochemical characterization of patients might be a future project I would bet on.
Yeah. You would bet 20 million euros on.
Personally, probably not. But if I was a researcher and if 20 million was available, I would definitely do that.
Yeah. So then it's the philosophy of the whole joint as an organ, and then
maybe even more. So a whole patient approach somehow, because what I'm also interested in is psychological effects. So there is some studies that really demonstrates also for cartilage treatment that this seems to play a role, and this is something which also contributes to patient profiling.
And you're also researching that the influence of your own patients with psychological effects on the outcome?
Actually, a fellow of mine who joined me for 2 years and who now moved to Boston, he actually published a paper on a resilience score in total knee arthroplasty. And what they found was a good correlation between this score and outcome. And we have now started also to use that score for our knee patient. And what is really interesting is that we do see significant differences independence of the diagnosis of the patient. So an ACL ruptured patient seems to be much less affected by problems associated with resilience. But these chronic patients partially are significantly affected. And
chronic cartilage.
I don't have any outcome data available on that project yet, but I strongly believe that we will find some correlations. And the interesting about that is that you can influence that. So you can really do a teaching program maybe prior to surgery that improves resilience of the patients, and maybe this helps also to improve outcome. But this is more questions than answers.
But that's why we're also here to discuss about that. So maybe in 20 years you'll have also a psychologist or teacher that you can refer the patient to.
I could definitely imagine. Or even as an orthopedic surgeon, you might be better trained in order to first recognize these issues and maybe also influence that issues. Yeah.
Well, that's some very interesting ideas for the future.
Yeah, but just rough ideas. Really.
We can polarize them, and very, very interesting. So thank you for sharing those thoughts. We will take it with us, and I think the listeners will also really appreciate that. And then towards the closing of our podcast, because I think we're well on our way. The last questions that we always do are some unexpected questions to our to our guests. What is something
looking forward to that?
Yeah. What is something that most people or colleagues don't know about you?
Oh. There's many things, because most of my colleagues do know me as a surgeon and maybe from conferences, etc. But I do have a personal life. I have a family which I really love, and I'm doing a lot of sports. But maybe something which nobody knows, that actually became an orthopedic surgeon just by chance. During my studies, I never considered to become an orthopedic surgeon or trauma surgeon. I started doing my doctoral thesis in oncology, and this is something I'm today really proud of, because parts of my doctoral thesis was published as early as, I think it was early 2000s. And I was working at that point in the group of Ugo Sahin and Özlem Türeci, which are the founders of BioNTech now. And so I have a co-authorship with these, and that's something which makes me proud from a today's perspective.
That's something people don't know about you. And I think that the last one is just some tips towards our listeners. So for maybe young researchers, young surgeons in the orthoregenerative field, as part of the ON Foundation, what are 3 main tips that you would give them, maybe for a research project or getting involved?
I don't have any specific tips, to be honest. So I would really ask young researchers to do whatever they are really interested in, because when doing research and also when doing a clinical career as an orthopedic surgeon, you need to have some endurance. And probably the best motivation to show that endurance is being excited about what you're doing. That's a really general comment, but it's definitely true. And the other is that when I talk to experimental researchers, I have already mentioned that I'm a little bit disappointed that this from bench to bed mark process is so prolonged by these regulatory issues. And I would just encourage them not to be disappointed and still keep on working on their projects continuously. We do not know how this might change. Interestingly, when I started, the FDA in the US was always super strict, and in Europe it was much easier to get products into the patients. And now it's changing a little bit. So the FDA becomes more or favors more innovations than the European governments do. And maybe this is a trend which continues over time. Maybe this trend comes again back to Europe. And so this tip is just to show this endurance.
And don't get demotivated by this, but persist.
There's no reason for that.
Okay, well, thank you very much for being our guest on the podcast. I really appreciated it and really enjoyed it. And thanks again.
Thanks for giving me the chance to be your guest.
This was ONtheGO, the podcast on orthoregeneration. For more content, stay tuned at my.on-foundation.org. Thanks for listening and have a great day.